Hey, welcome to the second live case demonstration in Power Up Endo's 90-day Super GP course. I hope you found a ton of value in that upper anterior live case demonstration. We're going to be building on that and working our way all the way up to, like I mentioned, that big bad upper molar with an MB2. This case is slightly more complicated, but again, nothing that you can't handle in your general practice with the right training, the right mentorship, and the confidence, and that's what this course is intended to provide for you. All right, so this case specifically, this was a 42-year-old female patient that presented to my practice with some significant pain that started a week prior and that sort of faded away leading up to her appointment with me in my endo practice, okay? You can see very clearly that tooth number 29 has a very large restoration in close proximity to the pulp. The patient reports no major symptoms other than a lot of aching the week prior, like I mentioned, okay? And you always want to take a bite wing radiograph as well as a periapical radiograph, and we're going to go through those with you. And so you can see very clearly on the periapical film that the restoration appears to be even on the PA, very, very close to the pulp, and you can hopefully see that lesion on tooth number 29 in the apical area. You'll probably also appreciate the radiolucency between tooth numbers 29 and 30 in terms of the apical area. That's going to be your mental foramen. It's usually between the premolars. Here it appears to be closer to the area between the second bicuspid and the first molar. But nevertheless, the lesion's obviously there. When we do our cold testing, we discovered that the tooth is negative to cold. And the adjacent teeth, number 28 and 30, both had positive responses to cold. Additionally, the patient had quite a bit of discomfort upon percussion. And so the combination of negative to cold and positive to percussion leads us to a diagnosis, and you should already know this now that you've learned it in the didactic lessons, okay? A diagnosis of pulp necrosis with symptomatic apical periodontitis. So it's important in cases like this to start the decision-making process on whether or not you're going to complete this case in a single visit or you're going to break it up into two with a inter-appointment medicament of calcium hydroxide. All right, so I have a whole bonus module dedicated to this topic because it's a topic that you're going to grapple with, and every provider that performs endodontic treatment grapples with on a regular basis, oftentimes even a day-to-day basis, okay, depending on how much endodontics you perform. And there's a lot of factors that go into whether or not you're going to decide to treat a case in a single visit versus two visits, okay? And I'm going to go through all those factors with you and go over some literature with you to help you in that decision-making process. But generally speaking, historically, okay, vital cases were completed in a single visit and necrotic cases were broken up into two. All right, and that was the way that it was done for a long time. And there were a lot of studies that looked at the long-term prognosis on teeth that were treated in two visits versus one visit, and the results were mixed. However, there have been a series of meta-analysis that have been performed on this topic because it's such an important topic in endodontics. And when you start to take a zoomed-out view of a lot of these studies, these well-done studies, and start compiling all the numbers and working your statistics, a lot of these meta-analysis actually show that the long-term outcome of whether you treated an necrotic case in a single visit versus two visits, the long-term outcome is pretty much the same. Now, granted, you'll want to be aware on a case level that if you treat a necrotic case in a single visit, there are some potential negative sequelae that can precipitate or occur. All right. For instance, you can have a case that you obturated in one visit that's necrotic, where the patient has some significant pain in the days after the treatment. You can have a patient who develops some swelling that occurs after the treatment is done. And the issue that can happen with calcium hydroxide inter-appointment medicament as well. But when you have calcium hydroxide in there, it's easier to manage that emergency appointment as opposed to when you have a root filling, compacted into the root canal system. Now, granted, so what you might end up having happen in these like 1 in 50, 1 in 100 cases where it's completed in a single visit and it's a necrotic case, you may have to remove the entire root filling and, re-disinfect the tooth and possibly leave the tooth open. So, you're going to need to make this decision, fairly regularly, like I mentioned. But, there's a lot of factors that go into it. And so, while this is a case that I'm presenting where we actually treated it in a single visit and it's a necrotic case, not all necrotic cases are done in a single visit in this course even. So I'm presenting a case later on in the training program where it's a necrotic case, and we show you how to perform that in 2 visits with calcium hydroxide. But nevertheless, this is a single visit necrotic case that I'm presenting for you, so you can see all the different configurations of cases. And again, every case selected for this training program are cases that you can handle, that I've handpicked, that are bread and butter cases that I get all the time, and quite honestly are cases that you can very easily handle in your practices with the right training and with the right mentorship. All right, so let's get into it. So here we're placing the rubber dam on the tooth. This is a clamp number 2T on the premolar. That's our universal premolar clamp. And you can see I'm just removing the rubber dam off of the wings with my finger very easily. And when you're doing root canal treatments in general, it's a great idea to lower the occlusion on the teeth that you're working on. Okay, that's really important for 2 main reasons. So for number 1, you want to have a really stable reference point for your instrumentation, because the rubber stopper on your rotary files, needs to be ending at a very precise location every time, so that you know that you're actually instrumenting to the length that you think you're instrumenting to. Also, the reducing of the occlusion is going to lower oftentimes the post-operative pain that the patient experiences. All right, so you don't want to get that call on a Saturday night with a patient complaining that they have some pain to chewing, when you could have very easily managed that with some lowering of the occlusion. All right, so after anesthesia delivery, we go ahead and lower the occlusion after rubber dam isolation, and now we're going to start with our access preparation. And so we're starting here with our size 2 surgical length round burr, and we want to prepare dead center in cases like this. So you're going to slowly progress towards the chamber of the tooth. If you need to clear away some of that dentinal mud or debris, do that periodically so you can see very clearly, the angulation of the burr and exactly where that burr is penetrating into. And pretty soon you'll feel a little drop right when you get into that pulp chamber. That's what you're looking for. All right, and then you're going to start your canal identification. So the first bit of sodium hypochlorite is going to help with dissolving, and it's going to increase your visibility into the tooth. And then we're going to proceed into our canal identification. All right, we didn't even need an Endo Explorer for a case like this because the canal is pretty open. So we're using our ProTaper Gold SX rotary file. That's going to be our orifice opener, and that's going to start the initial component of opening up that canal space so we can get a lot of sodium hypochlorite in there. Okay, and if you get some debris, don't be shy about putting some hypochlorite along the surface of the tooth just to dissolve that debris and make sure we're working with a nice clean area. Okay, so now that we've we can see that we're in the canal. We have a nice initial shape in the coronal third of the root. Then we're going to proceed to our working length determination and our glide path preparation. So we have a size 10 file that we're introducing into the root canal, and you can see that this is a C file. C files I would recommend for sizes 8 and 10 because those are the files that oftentimes you're really working to get down to the apex with, and the C file gives you a little bit more strength. It's a little bit more rigid, and you don't really need this for the larger files. So sizes 15 and above, I would encourage you to use K files, which is what you see here with the little square on the top. That's the K file symbol. And we're just getting our working length with our electronic apex locator. All right, I'm finding here that the working length is 23 millimeters. So we're going to take a working length radiograph here, and you can see very clearly that that goes right to the apex, and I feel really, really good about that working length at 23 millimeters. So now we're going to proceed to our instrumentation phase, and we're going to start with our Vortex Blue 1504 rotary file, and we're going to take it all the way down to 23 millimeters, and we're going to start working our way up the ladder. And remember, between every single rotary file, we want to use a lot of sodium hypochlorite, again in a 50-50 dilution, to try to minimize any chances of a sodium hypochlorite accident, which I'll discuss in the postoperative complications section. So now we're moving on to our size 2004 Vortex Blue rotary file, and taking that all the way to 23 millimeters, and again rinsing with our sodium hypochlorite between the files. You know, when you're starting with the size 15 and working your way up, it's a very repetitive process, and that's nice. Your assistant appreciates that because he or she knows exactly how the procedure is going to go. And now we're with our size 25 Vortex Blue 04 rotary, and again sodium hypochlorite in between. And you will start to feel as you're working these files that you'll feel when the apical region of the file is engaging with the apex just by tactile sensation, and that's going to tell you that you've thoroughly cleaned. But we got a little ways to go here. So we have our size 3004 Vortex Blue rotary file, again to 23 millimeters. Every file, rotary file, other than our orifice opener, goes to length. That would be what I would recommend, and I'll discuss that in world number 3. But again, more sodium hypochlorite. The cumulative effect of all this sodium hypochlorite is really what's going to make the difference in terms of making sure that your case is fully disinfected. Okay? And now we got our size 35 Vortex Blue 04 taper rotary file. That's very, very good. And you know, you can see it's starting to look like a final shape internally. You'll notice that the walls look nice and clean as we get into our bigger rotary files. So lots and lots of sodium hypochlorite here. That's going to, like I said, make all the difference in your disinfection. And like I said, you can see that it's nice and clean in there. It's starting to take its final shape. And now we're introducing our size 40 Vortex Blue 04 taper rotary file. And that's going all the way to length again. And you can see, I can really feel the file engaging at the apex, which is what we want. We really want that apical region cleaned out. That's going to make all the difference. And that's what's going to give you the confidence to obturate these necrotic cases in a single visit. So this is now the disinfection stage of our case, where we're going to pass a lot of sodium hypochlorite through the tooth. Okay, don't be shy about passing, like I mentioned, between 10 and 20 milliliters of sodium hypochlorite through a case. I would encourage you to do that, especially for necrotic cases. So now we're aspirating out after we've done with our, initial bout of sodium hypochlorite, and we're introducing our 17% EDTA rinse. You don't need a whole lot of this, but you want to stick it in there, pass that through, let it soak for a little bit, and then you're going to aspirate out and go ahead and go back with our final rinse with the half-strength sodium hypochlorite. Okay, that's the EDTA is going to remove the smear layer within the tooth. And then the last flush with sodium hypochlorite is going to allow that cleaning action a little deeper into the tubules that have now become open from the administration of the EDTA. All right, so this is our final flush with our sodium hypochlorite that's going to complete the disinfection stage of our treatment. And you can see we have a nice, neat area that we're working with, okay? The assistant is holding the surgical suction tip right up against there, so there's no leakage at all of the sodium hypochlorite. And now we're going to progress to the obturation phase of the treatment. So we're gonna start with our ProTaper F2 paper points. That's the red that you see there. And those are nice because you really only need one of those to get the canal nice and dry. And this is our bioceramic BC sealer that we're gonna squirt right into the canal passively, so we're not squirting anything out. And once we've dunked the cone into the tip of the sealer, we're gonna go ahead and seat that cone all the way to length. You wanna make sure that you crimp the gutta percha cone so that you have a really obvious reference point to go by to make sure that it's seated all the way to length. And once we have that seated all the way to length, we're gonna take our radiograph, our cone fit radiograph, and you'll actually see that the gutta percha cone is slightly sticking out of the root here. So I felt that needed a little modification. So what we're going to do here is remove the gutta percha cone, and you'll just trim back the tip of the gutta percha cone ever so slightly, about 1 millimeter or so. And you want to be careful to not really handle the bulk of the gutta percha cone with your fingers, just in case you have a little bit of saliva or bacteria on your fingers. Remember, we want to treat this like a microbial culture, if you will. So once we've trimmed it, we're reseating that gutta percha cone and taking another cone fit radiograph just to make sure that the gutta percha cone is in the confines of the root, which is exactly what we see here. That little bit of sealer extrusion is no big deal. We just don't want that near the mental foramen ideally, but as long as the gutta percha cone is in the confines of the root, a little sealer extrusion is no big deal. And so now we're using our System B 08 tip to sear off the gutta percha right at the orifice. Okay, again, this is a form of obturation known as hydraulic condensation, and we're going to go ahead and sever that off at the orifice, and then start our compaction of gutta percha with our size 1 Buchanan hand plugger, and we're going to use the larger side of that Buchanan hand plugger. That's the red hand plugger. I recommend the red and the blue, size 1 and size 2, and they're both double-sided with different sizes on either end. So you're going to compact that gutta percha right at the orifice so you have a nice, neat area. You'll find that removal of the excess gutta percha and sealer is easier on posterior teeth than with anterior teeth oftentimes, just because you don't have so many nooks and crannies, and you usually have a smaller access preparation. But then we're going to rinse off all our excess sealer with your air water syringe. You're just going to spray a lot of water in there. That's going to do the trick. And you might find that you need to kind of play with the internal aspect with the paper point and maybe with the pluggers again, just to make sure you don't have any excess sealer internally, and to make sure that there's no flakes of gutta percha or anything like that. You want to have a nice clean area that's going to set you up for the phase, which is the restoration. And me as an endodontist, I'm going to be placing a provisional restoration or a temporary restoration, but I would encourage you, if you feel confident about the disinfection and the treatment, to go ahead and place your core buildup here. That's going to be a very, very profitable appointment, okay, because you're going to have the root canal treatment done, in less than 20 minutes once you get good at this, and the core buildup done in just a few minutes more. So think about how amazing of a service you're providing for the patient, minimizing the number of appointments, giving them this kind of treatment in the comfort of your own practice, which they're already happy going to your practice, obviously, since they're a patient of record, and going ahead and doing that for the patient. All right. Also, if you're going to temporize the case, here's your green sponge that I've placed into the access opening. And for certain cases, I would recommend using a Fuji 9 glass ionomer, which is what I do here. And I do that in most cases, not all, but most, because it's a little bit of a stronger temporary restoration. It's going to give your restoration a little more strength. It's going to minimize potential contamination if there is some leakage of the temporary. And we can see there, after we've taken off our rubber dam, we've taken our post-op radiograph, and our obturation looks good. The gutta percha is well adapted to the walls. It's at a length that I feel comfortable with, and you can see the temporary restoration there. So the patient was very, very happy, okay, obviously, because this treatment was performed in such a time-efficient manner with no pain, and they did very, very well and went back to their restorative dentist or their general dentist in order to have the tooth restored. Okay, so again, this is a kind of case that is a slam dunk for you. I think you really, really, really want to handle these kinds of cases in your practice, because they're no-brainers, they're practice builders, they're revenue boosters, and you have the skills to do this. I would encourage you to handle these kinds of cases. You just need the training, and that's what this is meant to do for you, okay? So you can power up your endo game and become a super GP. I hope you found a ton of value in this case. We're going to be going through, obviously, many, many more cases together. And you'll notice that there's a lot of repetition involved. A lot of the systems are the same that I'm presenting and teaching to you. And the idea is for you to see the systems in repetition so you feel more and more confident to handle these day-to-day and everyday cases that I perform, that you can very, very easily perform as well. All right, I'll see you in the next lesson and in the next live case demonstration.